Have you ever really stopped to think about where healthcare actually happens? Most of us, we picture hospitals, clinics, maybe those sterile white walls. But what if the really impactful moments in health are happening, like in your living room or at work or even the park down the street? And how do nurses fit into that bigger picture, the one that goes way beyond a hospital bed?
That's exactly the shift we're digging into today. Healthcare delivery, it's fundamentally changed. There's this huge growing need for services right where people actually live and work and, socialize.
Right. So today we're doing a deep dive into Chapter 3 of Fundamentals of Nursing. It's the 11th edition by Potter, Perry, Stockert, and Hall. We're focusing specifically on community-based nursing practice. Our mission here is really to unpack some key nursing concepts. Things like patient care principles, clinical decision making, safety, theory, evidence based practice, but all within this community setting. We want to make the complex terms feel a bit more accessible, show you how it applies in the real world, and explore all the different hats nurses wear to keep communities healthy. Basically, your shortcut to getting the pulse of community nursing.
Okay, so let's start with the foundation. Community-based healthcare. It's really a collaborative, patient-centered approach. But the big thing isn't just where it happens, it's how it shifts the focus. It moves from just treating illness to actively, building health where people are. It's about providing culturally appropriate care, promoting health, preventing disease, and that restorative care piece, especially when patients are transitioning, say, from the hospital back home.
And what makes a community truly healthy? It's way more than just not being sick, isn't it?
Oh, absolutely. We're talking about good access to health services, definitely. Strong preventive care. Think immunizations, screenings, lifestyle teaching, plus good nutrition, safety, chances for physical activity, oral health, environmental quality. And crucially, it has to include both mental and physical health support. It's holistic.
And nurses have been doing this for a long time, right? This isn't entirely new territory for the profession.
Not at all. Nurses have a really long, proud history in public health. They've always been leaders, making those critical clinical judgments that really shape community health services. That leadership is still vital today.
So, if care is moving out into our daily lives, where are we actually seeing nurses making this impact outside the usual hospital walls? It sounds like it could be anywhere.
It really can be. Community-based care happens in all sorts of non-traditional settings. Think about ambulatory clinics, maybe community hospice centers, senior centers, even places like parishes or schools. And these settings are so important because they break down barriers. They make care accessible for people who might otherwise just not be able to get it. Maybe they're elderly or lack easy transportation, things like that.
Okay, let's pause here because there are a few terms that sound similar and get used, well, almost interchangeably sometimes. We need to untangle them a bit. You mentioned community-oriented nursing as sort of the big umbrella.
Exactly. That's the broad category. And underneath that umbrella, you find community health nursing and public health nursing.
Okay, so community health nursing, what's its specific focus?
Community health nursing zeroes in on the healthcare of individuals, families, and groups within a specific community, like a neighborhood maybe. The main goal is to preserve, protect, promote, or maintain health for that group. It's about improving the quality of health and life right there.
Got it. So individuals and groups within a defined community, how does public health nursing differ then? It sounds bigger.
It is. Public health nursing takes a much wider view. It's actually a nursing specialty, and it requires understanding the needs of a whole population. Now, a population is just a collection of individuals who share one or more characteristics. It could be all high-risk infants in a city, or older adults, or maybe a specific ethnic group. Public health nurses delve into the factors influencing health, disease trends, environmental issues, even political processes that affect public policy.
Can you give an example? Make it a bit more concrete.
Sure. Imagine a public health nurse looking at data on playground injuries across a whole city. They see a pattern linked to hard surfaces. So they take that data, that evidence, and they might lobby the city council for policy changes, advocating for safer, shock-absorbing materials instead of asphalt or concrete under swings. It's about systemic change for the whole population.
Okay, that really helps clarify the distinction. One's more focused on the trees, the other on the whole forest, kind of. So then where does community-based nursing fit into this? How is it different from community-oriented?
Right, so community-based nursing is distinct. It takes place in community settings like a person's home or local clinic, but its focus is sharply on the needs of an individual or a family. The emphasis here is really on illness care, safety, managing acute or chronic conditions for specific people, enhancing their ability to care for themselves, promoting their autonomy and making health decisions. This requires applying clinical judgment directly to that patient and their family situation.
Okay. It definitely sounds like working in the community comes with its own set of challenges, maybe even more complex than in a controlled hospital setting.
Well, absolutely. The challenges are significant. You're dealing with the effects of political policy, social determinants of health, which we'll get into, rising health disparities, economic pressures. It all adds up. You see the impact in things like lack of insurance, increases in chronic illnesses like diabetes or heart disease, substance abuse issues, STIs, kids being under-immunized. Nurses are right there navigating these complex problems daily.
So, faced with these big, complex issues, what's the national strategy? Is there a framework guiding efforts?
There is. The U.S. Department of Health and Human Services has the Healthy People Initiative. Right now, it's Healthy People 2030. It sets these ongoing health goals for the whole U.S. population, and they update it every 10 years based on the latest data. The big goals are pretty ambitious. Increase life expectancy and quality of life, improve health literacy, achieve health equity, and crucially, eliminate those health disparities we mentioned.
And how does that translate into actual healthcare delivery? What are the key parts of making that happen?
It really comes down to three core components, and nurses are central to all of them. First is assessment. This means systematically collecting data about the population, monitoring health status, making sure you have access to good community health information. So like tracking local flu rates or COVID cases, or maybe identifying trends in adolescent pregnancy or motor vehicle accidents involving teen drivers. That data is the starting point.
Okay, so you gather the data. Then what? How does that information turn into action?
That leads right into the second component,
hmm
policy development and implementation. Health professionals, especially nurses, play a key role here. They use that assessment data to lead the development of public policies. A really stark example is Flint, Michigan, with the lead poisoning crisis. Nurses were absolutely instrumental, not just managing cases for affected kids, but also leading public health efforts, lobbying for changes, educating people about water filters. Their advocacy made a real difference. You also see nurses heavily involved in policy around the opioid epidemic, advocating for evidence-based treatment approaches.
That makes sense. Assessment informs policy. And the third piece, access to care, feels like the most direct benefit for people in the community.
It really is. This is all about making sure that essential community-wide health services are actually available and accessible to everyone. Think about things like ensuring there are good prenatal care programs available to all pregnant people, or community-wide disease prevention efforts like free blood pressure screenings or vaccination clinics.
Now, the source mentions a health services pyramid to help visualize how these services fit together. Can you sort of paint a picture of that for us?
Yeah, absolutely. Imagine a pyramid, okay?
Uh-huh.
5 levels. It shows how community-based services slot into the bigger healthcare picture. At the very bottom, the widest part, is population-based healthcare services. This is the big stuff: health promotion, disease prevention for everyone. Think citywide campaigns for flu shots, ensuring safe drinking water, maybe big public health ads about smoking cessation. It's foundational.
Okay, the base level is for the whole population. What's next?
Just above that, you've got clinical preventive services. Still preventive, but a bit more targeted to individuals. So your personal vaccinations, specific cancer screenings based on age or risk factors. Moving up again, the third level is primary health care. This is usually your first point of contact, your family doctor, a nurse practitioner clinic, routine care, managing common health problems.
And the top levels.
The fourth level is secondary health care. This is more specialized care, maybe seeing a specialist like a cardiologist or needing a hospital stay for something less complex. And right at the very top, the smallest section, is tertiary healthcare. This is highly specialized, intensive care complex surgeries managing rare diseases, things like specialized cancer centers or burn units. The idea of the pyramid is that if we have strong services at the bottom, population health and prevention, fewer people will hopefully need the more intensive, expensive care at the top.
That's a really clear way to visualize it. So even in, say, a rural area without a big hospital, that pyramid structure still helps understand the available services.
Exactly. That rural community might lack the top levels, the tertiary care, but it could still have strong primary care, clinical preventive services like immunizations, and maybe even local population-based initiatives focused on safety or nutrition. A nurse assessing that community uses this kind of framework to see what is there and, importantly, what gaps need filling. It's all about meeting the community's needs where they are.
You mentioned social determinants earlier. That seems crucial here. Beyond just the medical stuff, what are these underlying factors that really shape a community's health?
It's so important to understand this. Our health isn't just about genetics or lifestyle choices. It's deeply influenced by the conditions in which we're born, grow, live, work, and age. These are the social determinants of health. Healthy people, 2030 groups them into 5 key areas: economic stability, education access and quality, healthcare access and quality, the neighborhood and built environment like housing, parks, walkability, and the social and community context, things like social cohesion, civic participation, discrimination. It really drives home that health truly starts where we live, learn, work, and play.
And when there are inequities in those determinants, that's where health disparities come in, right?
Precisely. Health disparities are those differences in health outcomes between groups that are preventable and unjust. They often stem from systemic obstacles, things linked to race or ethnicity, socioeconomic status, gender, sexual orientation, geographic location, disability.
Mm.
It's usually not just one factor, but a complex mix of things like poverty, environmental risks, poor access to care, maybe educational inequalities. Understanding this is absolutely vital for nurses working in the community.
Yeah. As you're listening, maybe take a moment to think. What health disparities do you actually see or know about in your own community? It really brings this concept home.
And these disparities often hit certain groups harder. We call these vulnerable populations. These are groups who are more likely to develop health problems because they face more health risks, have limited access to care, or maybe depend on others for their care. They're often the main people community nurses work with.
Can you give us some examples of these vulnerable populations and what specific things a nurse needs to keep in mind?
Sure. Let's take the immigrant population. They might face challenges like language barriers, poverty, lack of insurance or resources, maybe stress related to acculturation. They can also have higher rates of certain conditions like hypertension or diabetes. So a nurse needs to be culturally sensitive, aware of non-traditional healing practices perhaps, and really attuned to both the physical and psychological stressors they might be facing. Language access is huge here too.
What about people experiencing poverty or homelessness?
This group faces immense health challenges, often living in hazardous environments, maybe working high-risk jobs. Poor nutrition is common. Lack of transportation is a huge barrier to care. They often end up relying on emergency rooms for basic needs, which isn't ideal. Nurses working with this population need to be incredibly resourceful, connecting people to food banks, shelters, transportation assistance, job resources, while also advocating for policies that address the root causes of poverty and homelessness.
And another group mentioned is patients who are abused. That's a tough one.
It is. And it's a major public health problem affecting all ages, genders, and socioeconomic groups, though older adults, women, and children are particularly vulnerable. Nurses need to be skilled at creating a safe, private space for assessment. Therapeutic communication is key, making it clear it's never the victim's fault. And importantly, nurses need to know their state's mandatory reporting laws for a suspected abuse or neglect of children, older adults, and individuals with disabilities.
Also, patients with mental illness?
Yes, many individuals with mental illness face significant barriers: homelessness, poverty, unemployment, stigma, and real difficulty navigating the healthcare system. There's been a shift away from long-term hospitalization towards community-based care, which is good, but it means the community resources need to be robust. Nurses play a vital role in coordinating care, medication management, counseling, housing support, vocational assistance. It requires a comprehensive approach.
And finally, older adults.
With the population aging, this is a huge focus for community nursing. The demand for services tailored to older adults is growing rapidly. Nurses need to understand how older adults define health for themselves, promote safe physical activity, manage chronic conditions which are common, address sensory impairments like vision or hearing loss, watch for cognitive changes, and be aware of potential issues like medication mismanagement or social isolation. It's about supporting their function and quality of life as they age in place.
Okay, so shifting gears slightly, how does the bigger picture, like global health issues, connect back to what's happening in local communities?
That's a great question because we're more interconnected than ever. Global health is about understanding health issues internationally and working towards health equity worldwide. The World Health Organization, the WHO, leads a lot of this work. Their priorities often directly impact local communities. Think about equitable access to vaccines. We saw that clearly with COVID-19. Or issues like air pollution and climate change, the spread of infectious diseases, access to essential medications, healthcare worker shortages, even things like ensuring clean water and sanitation. These global challenges have very real local consequences.
And things like pandemics really highlight that connection, don't they?
Absolutely. Emerging infectious diseases like Ebola, H1N1, SARS, Zika, and of course COVID-19 show how quickly things can spread globally due to increased travel, dense populations, and even climate change impacting disease vectors. These outbreaks cause massive disruptions, not just illness and death, but economic impact, school closures, supply chain issues, and huge mental health tolls.
And nurses are right on the front lines during these crises.
Completely. Nurses are essential. They're caregivers, obviously, but also educators teaching about sanitation, disease prevention. They manage critical supplies and equipment, act as liaisons between patients, families, and public health officials, and they're often investigators on community health teams doing contact tracing and monitoring. Their role is incredibly broad and critical in any public health emergency.
So, given all this complexity, the different settings, populations, challenges, what does a nurse really need to succeed in community-based practice? What are those core skills?
It really requires a blend of skills and talents. Community nurses use the nursing process, critical thinking, just like in any setting, but they have to adapt it constantly to the community context. They need to be adept at building relationships, promoting health, and preventing disease in diverse environments.
Let's break down some of those specific roles mentioned in the text. First, the caregiver role. How is it different in the community?
As a caregiver in the community, you're managing the health of patients and families, but you have to tailor everything to their specific environment. So for instance, if you recommend an exercise program for someone with diabetes, you don't just say exercise more. You might ask about safe places to walk nearby, maybe suggest a specific local park or a program at the community center. It's about making care practical and achievable within their life context.
Okay, and the case manager role sounds really important, especially for patients juggling multiple health issues or providers.
Definitely. The case manager is crucial for coordinating care. They develop the care plan, connect the patient with necessary resources and services, and ensure smooth transitions between different levels of care, maybe from hospital to home health to outpatient clinics. Let's take that example of Maria Perez again, the 74-year-old widow with heart failure and falls. As a case manager, the nurse needs to do a thorough home assessment. Throw rugs, poor lighting. How is she managing her medications? Is she isolated? Then the nurse coordinates maybe getting a physical therapist for fall prevention, arranging medication reminders or pre-filled pill boxes, connecting her with Meals on Wheels or a senior center. It's about pulling all the pieces together from the community resources available. This directly ties into NCLEX competencies around care management and safety.
What about being a change agent? That sounds proactive.
It is. As a change agent, the nurse isn't just following orders. They're identifying problems and implementing new, better ways to address them. This could be on an individual level, empowering a patient to find solutions, like helping someone figure out transportation to get to a clinic that has better hours for their work schedule. Or it could be bigger picture, working within an agency or the community to advocate for policy changes or new programs based on identified needs. It often requires gathering evidence, building consensus, and sometimes navigating resistance to make change happen.
And the patient advocate role seems fundamental.
Absolutely fundamental. Nurses advocate for their patients' rights and wishes within the complex healthcare system. This means ensuring they have the information they need to make informed decisions, helping them understand their options, and supporting the choices they make, even if those choices differ from what the healthcare team might recommend. It's about amplifying the patient's voice.
Collaboration must be key too, right? You're not working in isolation.
Not at all. The collaborator role is huge. Community nurses work closely with patients, families, doctors, social workers, therapists, pharmacists, home health aides, school staff, clergy, you name it. Effective collaboration relies on mutual trust, respect, and clear communication to ensure everyone is working towards the patient's goals. Think about hospice care that requires tight collaboration between the nurse, physician, social worker, chaplain, and family.
And counselor, how does that fit in?
As a counselor, the nurse helps patients identify their health problems, explore their feelings and options, and choose appropriate actions. This isn't necessarily formal therapy, but involves therapeutic communication, active listening, and helping patients tap into their own strengths and community resources. Techniques like motivational interviewing can be really helpful here, guiding patients to identify their own reasons for change and overcome barriers, maybe connecting them to a support group or respite care services.
Education seems woven through all of this.
It really is. The educator role is constant. Nurses are always assessing what patients and families need to learn, whether they're ready to learn, and tailoring the teaching approach. This happens in formal settings like prenatal classes or diabetes education programs, but also informally during every home visit or clinic encounter. Teaching about medications, diet, exercise, warning signs, navigating resources, it's ongoing and vital for empowering self-management. Effective patient education is a major NCLEX focus area.
And lastly, the epidemiologist role. That sounds quite specialized.
It does, but community nurses use epidemiological principles all the time, even if they don't have the formal title. Epidemiology is about understanding the incidence, distribution, and control of diseases in populations. So, a community nurse might be involved in case finding, like identifying people exposed to tuberculosis. They track incident rates, maybe seeing an uptick in lead levels in kids in a certain neighborhood, or a rise in adolescent pregnancies. They use this data for health teaching and to target interventions where they're needed most.
Wow, that's a lot of hats to wear. So, before a nurse can even start doing all that effectively, they need to understand the specific community, right? That brings us back to community assessment.
Exactly, it's the foundation. Community assessment is that systematic process of collecting data on the population, monitoring health status, and sharing that information back with the community. You absolutely have to understand the environment, the strengths, the challenges, the resources, the culture where your patients live, work, and learn. Without that deep understanding, your interventions might miss the mark entirely. It's how you make care truly relevant and patient-centered.
And the source outlines three main components to look at in an assessment. What are they?
Okay, first is the structure or locale. This is the physical environment. What does the neighborhood look like? Where are services located? Are there safe places for people to gather or exercise? Are there environmental hazards, poor air quality, contaminated soil, unsafe water? What about safety issues like abandoned buildings or lack of sidewalks? You also gather demographic stats here using reliable sources like public health department websites or census data.
So, the physical place, what's the second component?
The second is the people, the population itself. Here you're digging into demographics, age distribution, sex ratio, population density, growth trends, education levels, income levels, the predominant ethnic and religious groups. Understanding who makes up the community is critical for tailoring programs.
Structure, people. And the third?
The third is social systems. This means learning about the existing systems that influence life in the community. What's the school system like? What local government services exist? How do people communicate local newspapers, social media groups? What welfare or volunteer programs are active? And of course, what does the health system itself look like? Clinics, hospitals, mental health services. You gather this info by observing, reading reports, but also by talking to people, community leaders, residents, other service providers. Once you have this big picture, then you can assess individual patients effectively, understanding the context of their lives, their safety, and the resources potentially available to them.
That makes so much sense. As you're listening, maybe try doing a quick informal community assessment of the area around your school or where you work. What do you notice about the structure, the people, the social systems? It's a really practical way to start thinking like a community nurse.
Absolutely. And all of this leads towards the goal of changing patients' health, ideally using evidence-based practice or EBP. In community nursing, ensuring continuity of care and using interventions proven to be effective is just crucial.
The book gives a good EBP example related to childhood obesity, particularly in racial and ethnic minority populations. What was the core question driving that?
Right, the PICOT question was essentially, do community-based interventions targeting families actually reduce childhood obesity rates among diverse populations? The evidence showed, yeah, obesity is more prevalent in these groups, and it's complex. Lots of factors involved like genetics, biology, social factors, environment, lifestyle, socioeconomic status, and importantly, it has lifelong health consequences, so intervening early is really key. Adult perceptions and family support were also highlighted as critical.
So what did the evidence say about what works in the community?
It really emphasized community engagement. Things like culturally relevant workshops, using local media, building collaborative partnerships. These approaches had high success rates, especially with racial and ethnic minority kids. Public policy also matters, ensuring access to affordable healthy foods, creating safe places for physical activity, like fixing up neglected parks. It takes a multi-pronged approach.
And for nurses on the ground, what are the practical takeaways from this EBP?
Key actions include really understanding the modifiable risk factors in their specific community, designing interventions, diet, physical activity that are not just evidence-based, but also culturally sensitive and linguistically appropriate, And a really interesting point was engaging youth themselves as leaders in prevention efforts. But underlying all of it, the evidence reinforces the need to build those strong, trusting relationships with patients and families. You have to understand their lives, their values, to co-create interventions that actually work for them. That's patient-centered care in action, and it aligns perfectly with NCLEX priorities around health promotion and applying evidence.
So wrapping this all up, what's the big takeaway for you, whether you're heading into nursing or already practicing?
I think this deep dive really shows just how vital community-based nursing is. It's not an afterthought. It's central to healthcare now. We've talked about the incredibly diverse roles nurses play way beyond bedside care and the very real challenges they navigate, from policy issues to social determinants. Frameworks like Healthy People 2030 give direction, but it comes down to that holistic approach, looking at the whole person within their whole community, especially when working with vulnerable groups. Maybe the final thought to leave you with is this. How can you, in your role as a nurse, make a unique contribution to building a healthier community? How can you really understand and, more importantly, act on those social and environmental factors shaping your patient's health? What's one creative, proactive step you could take, maybe outside the traditional clinic walls, to foster genuine well-being?
That's a great question to ponder. A fantastic challenge for all of us in nursing. Thank you so much for joining us on this deep dive today. We really appreciate you being part of our learning community. From everyone here at the Deep Dive and the Last Minute Lecture team, thanks for listening.